As everyone is aware, GLP-1 medication therapy is a very hot topic right now, particularly for employers, health plans, and for members. So today we're going to cover a few things. Dr. Rachel Daughtry is going to give us a clinical perspective on how these drugs work, the clinical value and efficacy, and the population health benefits. And then we'll turn it over to Dan Shields, who is the CEO of Digital Medicine, who will take us through how Ochsner is balancing these challenges as a 30,000 live health plan and as a provider of care, and how we're managing these things ourselves.
I'm going to talk a little bit now about the media portrayal of these medications. Like Katie referenced, these are a hot topic. They're all over social media. They're all over, even regular news outlets, and celebrities are taking them. And so you hear a lot about these medications. And unfortunately, I think a lot of the sensationalism that's surrounding them has had a negative impact on how they're perceived, both in, the general population, as well as people in the medical field, professionals in the medical field. And, it doesn't help that you can go to kind of boutique like medical spas and weight loss clinics and get compounded formulas of these. And I think that's kind of only perpetuated the unfortunately bad reputation that sometimes these medications can have. They're kind of perceived as more like snake oil than being a promising new treatment for a chronic disease. And so I think it's important that patients can get this medication that's provided to them in a safe environment, and that they have affordable access to the medications. Because obesity, as I'm about to discuss with you, it's a disease, and it's a big problem in the United States. So, like I just alluded to, obesity is a disease that's recognized as such by the World Health Organization and the American Medical Association. It's a disease in which excess body fat and adipose tissue leads to a lot of inflammation, a pro-inflammatory state. And it's associated with over 200 comorbidities. So some of the more common ones we hear are type 2 diabetes, hypertension, dyslipidemia, they're cardiovascular diseases. Cancer, many cancers are associated with obesity, especially breast cancer, colon cancer, ovarian cancer. Our osteoarthritis. So some of the impacts of having that excess fat tissue on our joints, obstructive sleep apnea, not being able to breathe as well. Non-alcoholic fatty liver disease is another problem that's becoming more and more common, and the only treatment of that is to lose weight. So, looking at what's driving these rising rates, like I mentioned before, this kind of sustained energy imbalance. So what's been happening over time, our food quality has decreased. We're cooking at home less. There's more restaurants and fast food establishments. We're relying more heavily on highly processed convenience foods. So all these have led to us eating less real food and more of these highly processed foods that, may have more chemicals and preservatives and all in them. Food portions have also increased. So, excuse me. So, and, if you look at this graphic, I find very interesting that when some of these items, beer, French fries, soft drinks, and all, when they were first available to the public, the sizes and how they have increased over time. And this is, back in 2002. So I'm sure now it's probably even higher sizes available. Additionally, so while we're eating more and eating less quality foods, our activity has decreased significantly over time. With shifts in industrialization and technology, we've moved away from a lot of physical labor-intensive jobs to more sedentary desk jobs. And really since COVID, that's probably worsened, because now we're no longer even having to walk to our cars to get to our offices, or having to walk around the office. Now a lot of us are at home working from home, again in front of a computer screen. And then even when we leave work on our free time, there's a increase in passive entertainment. So again, we're looking at sitting down, looking at screens, cable TV, streaming services, the internet, online shopping, video games. All of these combined have reduced greatly our physical activity and just how many calories we're naturally burning in a day. We have, transportation. Cars are readily available, public transportation, whereas years ago, you would have to walk places to get anywhere. So there's just been a lot of, conveniences that have taken away from a lot of the activity that we normally would have had before. Looking at some of the economic costs of obesity. So, like I said, the obesity is associated with a lot of comorbidities, so a lot of chronic disease. And so with each 1 unit of BMI increase over 30, it's estimated that costs about $253 per person. Obesity among adults is associated with an excess 1,861 annually per person. With severe obesity, again, being, the 35, 40 and BMIs, they're at $3,097 per adult. And then the total cost of chronic diseases associated with obesity has been estimated to be about $1.72 trillion. So I think, that kind of brings the point home that we need to have a safe, affordable access to some of these medications that can really help patients who are struggling with the disease of obesity. And they need to be able to go to hopefully their physicians and all to get these medications.
Just to kind of sum up everything Dr. Dotry went through, as a provider of care and as a health system and a clinical organization, you've probably seen from what Dr. Dotry took you through that we believe that these are very important medications. These are very effective medications, things that can do a lot of good for a lot of people. But much like I'm sure many of you on the phone, and we've got a pretty good mix of both employers, consultants, brokerage houses, as well as carriers and clinical folks. It's actually a pretty nice cross section. But one of the challenges we have as an organization is probably the same thing, despite our belief in these medications, that we have the same challenges that everybody else does as an employer. We have about 38,000 employees. We believe in covering these medications, but when we did open up the potential to cover these medications, we obviously saw the other side effect, which is the very high cost of these drugs. And like any other employer, we started to see, not only the high cost of the drugs, but like many people are reporting, the instances of people that are on this drug that maybe should not be. So kind of the inappropriate use of them as well. And one thing, I don't want to speak for Dr. Dotry, but a big believer in the medications, but obviously when used appropriately, and that's an important part. So like a lot of you, we were looking for ways that we could continue to do what we think is the right thing for our plan members and our patients and our employees, while at the same time mitigating and putting some guardrails around where this cost came from. Because if you look at our plan, it's much like probably many of yours that you might know about. It's a large employer. We do want people to have access to these drugs. We want to make sure that's done by, as Dr. Daughtry said, in a safe and effective way, through the appropriate clinical channels. And we also looked at the fact that this is something that's becoming more and more expected. You guys might have seen that a recent survey did find that a large chunk of people, as much as 44, responded that they would look, often we see that people will change jobs for benefits and for coverages, but specifically around the coverage for this type of treatment. So we ended up running into looking at a couple of different ways that we could mitigate this cost. And I think the earliest answer, much like we see from other employers we talk to and other plans, is can we put in some sort of a prior auth or pre-authorization mechanism with the PBM or with the pharmacy provider. And what we realized very quickly in working with our provider is that it was very difficult to manage. It would actually be very, not only a difficult thing to administer for any PBM, but also it really started to erode the member experience and our employees' experience, in that, one, there's not a lot of data you can track to do a traditional data-driven prior authorization. So, for example, you don't necessarily have everyone's BMI. You don't know if they're in a weight management program, which is, believe it or not, one of the initial prerequisites for these drugs. So what it ultimately boils down to is a medication review where the PBM calls the doctor that prescribed it and said, do you really want them on it? And they say, yes, otherwise I wouldn't have written the script. So it's just a very difficult process. So we said, well, let's look at a different way to do that. And by coincidence, as many of you know, we offer and have offered for several years now a program to both our employees and our patients, and then nationally to other employers and other carrier relationships, a diabetes and hypertension program that we manage digitally. And one of the things that we've been working on in our roadmap on our digital health world was how can we expand that offering to include things like prediabetes, weight management, to really kind of more encompass what's become known as that cardiometabolic conditions. So we really saw an interesting intersection of a need from our own employees coming with something we were doing in digital health. And we really decided that digital medicine was our best solution to put these guardrails in place. So it is, we built a weight management program, something that we were building anyway, something that really focuses on the ability to use a combination of both in-person and digital coaching, access to dietitians, access to health coaches for members that do struggle with that weight, or either in the overweight to obese to pre-diabetes category as well. But what we've decided to do is incorporate in the management of those medications into that program as well. And we were already set up to do this because our clinicians in hypertension and diabetes are already licensed in all 50 states. They already have the authority and the ability to order labs and to prescribe medications. So we already had the infrastructure in place to add this into it and kind of make it more of a combined program. So we have that weight loss program to get people to help manage their weight. What we've layered on top of that is a medication management program specific for these GLPs. And what that does is looks at, again, only those members or those patients, in this case, that are 100% in compliance with the clinical guidelines to manage that drug. And the first one, believe it or not, and the toughest one, as I said, to track is, are they in a weight management program? Because it's not just about giving them these drugs to lose that initial and give them that head start. It is about, are they learning those behavior changes too, so that when and if they're able to get off the drug, do they not immediately regain the weight? So we look at those people that are above that BMI, which is the clinical guidelines for the drug, or 27, if they're over 30, or 27 if they have some sort of comorbidity. We will then set them up with a clinician who's licensed in the state that they're in. And we do have employees, while we have a large Gulf contingent, we do have employees in a number of states and all over the country. So we had to make sure this was something we could support nationally. We'll then set them up with a virtual visit. We'll have one of our clinicians review the medications, make sure it's appropriate for them, make sure that there are none of those conditions that Dr. Darby mentioned that would be a contraindication to the drug. And then ultimately, they will write the script, and they will write the script for and manage the medications for that particular member. So what that allowed us to do is not only ensure that the people that were written through this program are 100% managing and meeting the clinical criteria, there is no off-label writing. What we did, and we're able to do, with really any PBM at this point, is we wrote the program in such a way that our health plan, our employee health plan, is only covering the cost of the drug if it is written through the weight management program. So we've been able to give those guardrails through the prescription rights to the program, not necessarily things like prior auth through the PBM. And that's actually been very simple to do, in that we just worked with the PBM to say, if it's not written by these clinicians that are in this program, it's not covered. So it kind of ended up becoming the best of both worlds for us and for our employee health plan, and obviously for the dollars and cents side of it as well, in that we're able to offer these drugs to, which we feel are very important to our employees. And we're able to give them a fairly easy way to get to it, and in a safe and a very obviously highly clinical environment, while at the same time providing, that gatekeeper, if you will, to make sure that we're not at least covering when people are getting these drugs outside of the true clinical guidelines for that particular program. So we kind of, as we often do, and if I know many of you on the phone have kind of heard our story before, whenever we launch a new program, and our hypertension diabetes program was actually launched 10 years ago, started in our patient population, then moved from there into our employee populations, and then from there into some of our carrier and our other employer relationships. We're doing the same thing here. We've actually built this as an internal solution to make sure we're solving a problem first, and then having that ability to offer that externally as well. So the program itself, just to whether it be what we're rendering for our own employees or what we can do externally, is developed by us internally as an academic health system. We are actually a bariatric center of excellence. I don't mean to embarrass Dr. Daughtry, but she's an expert in the field, and hopefully you can see that from her conversation today. It is that full clinical management, again, backed by a health system. But again, it's not just a mechanism to write a drug. There's all kinds of different ways you can get a drug into people's hands. This is really designed to not only get them into the program, get them access to these really effective drugs, but at the same time bring to bear dietitians, nutritional counseling, both digital and in person, a little bit of gamification in there as well, and the ability to actually get people to learn these behaviors so that they can, while they're getting that that jump start, the head start with the use of these drugs, they can then learn what they need to do to actually change their behaviors as well. And then obviously, like anything else, we need to make sure both for our internal purposes and externally, are we tracking it, and is it are we making sure that it's effective? So it's not only who's in the program, how people are engaged, but is it being successful? And we can do that by tracking through. Are we seeing those percentages of weights? Are we that we want people to lose? Are we seeing the then downstream effect, which again, if you then couple this with hypertension and diabetes, are less people moving into that diabetes side? Are they moving less into the hypertension or high cholesterol and moving down that continuum? Because as Dr. Daughtry said, if someone is, and I know I'm preaching to the choir for many people on the phone, but if they're in that category of obese, they're already a little bit more expensive than the typical member. But if anyone looks at your claims data reports, which I'm sure you do, someone who is obese is a little more expensive than average. Someone who has a hypertensive or hyperlipidemia is more expensive than that, and then diabetes more expensive than that. So not that it's all about cost, but when you talk about the efficacy of these programs, it's really about keeping people either out of or keeping them from moving between those different levels of this kind of continuum of care. And that's really what we're looking to do here. So if you consider that whole spectrum of what has become known as cardiometabolic care, and this continues to evolve as far as how clinicians and how the industry looks at these different conditions and how they group them together, but that continuum of someone who's otherwise healthy and lower risk all the way through to high risk and multiple comorbidities of hypertension, diabetes, high cholesterol, maybe even moving into chronic kidney disease. The whole purpose of this program is to keep people from moving, if they get into the spectrum, no matter where they are, not progressing through it. And we really take a very, obviously, highly clinical approach towards that to make sure that we're trying to intervene at the right place. So with the combination of weight management, these medications, combined with what we've always done in cholesterol and hypertension and diabetes, we're really at a point where whatever member comes to us, no matter where they are in this world, we can apply the correct coach, the correct dietitian, the correct medication, the correct treatment to try to keep them where they are and help to manage them, based on where they are in that particular world. This focuses highly on our program as hypertension, diabetes, which we're not in weight management too. But the most important thing and takeaway from this is we routinely see excellent clinical outcomes. And I would say these are studied not only internally ourselves as a health system, but also through third-party actuaries, through the things like the actuary or through the Validation Institute, which many of you are familiar with. Most importantly, people tend to like the program, so our Net Promoter Score is pretty high. We won't go through individual numbers, but mostly just to say that everything that we do is driven on getting those outcomes first, making sure it's an excellent member experience, an excellent patient experience, so that ultimately, once we get people in, no matter where they are in that continuum, we're making sure they're getting excellent care, and we're meeting that triple aim, which is looking at outcomes, quality, cost, and then that patient experience and member experience as well.